Okay, we're going to start because we don't have a lot of time to cover a big topic.
Huge topic.
Yeah. I'm Laura Melville. I'm from NYP Brooklyn Methodist Hospital. I'm the Associate Research Director and the SAFE Medical Director.
And I'm Mary McLean. I'm the Associate Program Director at Advent Health East Orlando and the Residency Research Director as well.
All right. Shall we click? Oh, clicker's not working. All right, great. Technical troubles, not a problem. We have no financial disclosures. We're both open to discussion if anybody would like to pay us to talk about the pelvic exam. And we have some objectives. They're pretty lofty objectives. I'm not sure that we're actually going to reach them all, but we really want you to get a sense of kind of the history behind gynecologic care and the pelvic exam, how that's kind of created an environment where the care isn't so adequate, and look at some of the literature, but there's not a lot of literature to really look at, which is part of why the care is inadequate, and outline some strategies to improve patient experience and your comfort, and give you some protocols on how to perform a good pelvic exam and GYN history. So where do we begin? Well, we begin as far back as we can, and the earliest written description of what appears to be gynecologic care, I'm not going to make you read the whole thing, but it essentially involves a prayer requesting that the womb stay in place, that it not wander around, try to chew at the ribs. Is this really echoey? Yeah? Okay. I'm just going to be loud. I'm pretty loud. Whoa. All right, we'll just go. Saying, stay in place and don't eat at the ribs and don't eat at the heart and, behave and stay put. And we're praying to a god for this. So the earliest wandering womb theory from about 4th century BC.
All right. And then we fast forward to the mid to late 1800s. James Marion Sims. I'm sure you guys have heard the name, but he was highly revered by many as the father of modern gynecology, practiced in the mid 1800s through the late 1800s, and he did a lot of things. He invented essentially the early version of what we still use today as the modern speculum. And he was a big name in his time. He was an AMA president. He was a founding member of the American Gynecologic Society and later was a president of that society. And he created a lot of surgical procedures that are still used today for things like rectovaginal fistula and OBGYN procedures and things like that. And essentially around the United States, there were about 6 statues of him that were erected in his honor because he was such a big name. However, he was also described as a torturing slave owner. He purchased female slaves, kept them on the hospital grounds, and performed experimental procedures on them, surgeries, and did not use anesthesia. Said Black people could not feel pain, and that was how he justified it. And that was essentially the way that he came up with all of these experimental procedures. It caused a lot of pain. This painting is a depiction of the lead up to one such procedure with 3 of the slaves that he did experimentations on. Their names are Lucy, Anarcha, and Betsy. And we will come back to this painting toward the end of the talk, but essentially when it came out that there was so much controversy and ethicists were likening his practices to Tuskegee and Henrietta Lacks, they pulled down a lot of the statues around the United States, including the Central Park one that we had showed on the previous slide. Now, that provides a little bit of historical context. Today, there are still severe restrictions to women's health, and things seem to be getting a little bit worse in the last few years. And you can see here, some of the states in the United States tend to be the most restrictive, those dark red colored, and it tends to be more in the middle of the US and the South. How about the emergency department? What are we doing and what can we do to rectify this? Now, this comes down to, are we performing the pelvic exam in the in the emergency departments across the US? A lot of times the answer is no. Are we providing the adequate gynecologic care that we should be? A lot of times the answer is no. And I do have some evidence to back up the fact that maybe we just don't like doing the pelvic exam. So there was a study that was published in Academic Emergency Medicine 2016 that essentially did a retrospective review of 30,000 patient records and looked at the time between patient rooming and resident self-assignment and used that as a surrogate for chief complaint preference because they looked at all of the different ED chief complaints. And you can see all the way over here on the right for being the second least preferred chief complaint, it's vaginal bleeding. The assumption being that that patient may require a pelvic exam. Can any of you guess what the category or the complaint all the way on the right is? That's a good one. That's a good one. It's other.
So longest time to be seen.
Longest time to be seen, except for other. All right. So do we actually need the pelvic exam? Now, this is a really, it's a valid question, and it's been brought up in the literature multiple times in the last couple of decades. There have been lots of studies that are arguing that it's an uncomfortable exam for patients, that it increases the ED length of stay. There's a lack of resources available for doing the exam, like chaperones, private rooms, those kinds of things. And then some studies have suggested we shouldn't be doing it because of poor inter-rater reliability of things like the bimanual pelvic exam. And other studies have suggested that the pelvic exam rarely changes our ED management and diagnosis, especially in cases of first trimester vaginal bleeding. Now, probably the best study to come out in recent years was Annals of Emergency Medicine 2017, this study. It was a prospective randomized equivalence trial. It was the largest of its kind to date. And I'm going to skip to the conclusions here. They essentially found, and I quote, "This study provides additional data that support the safety of omitting a pelvic examination in women with a confirmed IUP on ultrasonography unless there are specific clinical concerns such as infection or trauma." Now, I want you to keep that conclusion in mind as we go through a tiny bit more about the study parameters and things like that. So investigators, they looked at composite morbidity in both a pelvic exam and no pelvic exam group, and they compared them. The problem here is that it was far underpowered. They had a high potential of bias. They actually excluded about 70% of the eligible participants in the study. It was a convenient sample. Anyone who didn't speak English was not enrolled. If the provider chose not to do a pelvic exam, then they could be excluded. If the patient didn't want a pelvic exam, of course, they could be excluded. But essentially, the amount of bias that was wheedled into this study was significant. And on top of that, they had no statistically significant findings. So remember the conclusions in that context.
And also, I think you may have found that your residents have been trying to apply this to every patient who needs a GYN exam. So this was a very specific group, intrauterine pregnancy, and not, without other significant issues, confirmed on ultrasound prior to potentially getting a pelvic exam. Very narrow group, not meant to be applied to all women with any gynecologic related complaint.
And that's a really good point because, us both being resident educators, we are, our residents have been hanging their hat on this study and other studies like it as a reason to not do a pelvic exam. Now, is it really that it's not indicated, or is it that they just don't want to do the exam and they want an excuse? It's really, it's difficult to tell, but at this point, we don't have evidence to omit the pelvic exam. There is no study that has done a good job that's not biased, that's powered adequately, et cetera, et cetera. So essentially, 2 years after that publication, so in 2019, there was a task force that was out of Canada. It was the family medicine, obstetrics, gynecology, and they came out with key recommendations for indications for a pelvic exam. 2 of the 4 of which do apply to our practice in the United States and in emergency departments. So symptomatic gynecologic complaints must be investigated with a pelvic exam, and current task force statements on pelvic exams should not be interpreted to mean it's non-contributory to care. So those are the mantras that I recommend everyone live by.
So we've already heard that people have been arguing that we don't need a pelvic exam, and we're arguing to you that it's not time to get rid of the pelvic exam. But what maybe we need to do is figure out a way to make it better so we can make it better for patients. We've tried to look at the research on that. There is very little. Once again, very unsurprising. So if anybody here needs a research project, maybe a qualitative study of GYN patients, what would make them more comfortable with the pelvic exam? Great start. It's not been done. There is some data out there that says, there are some that's looked at some small things like different kinds of gowns does that make patients more comfortable? Different, having a conversation beforehand to discuss trauma. And then one in particular talked about ways to position patients that might be a little more comfortable. And I like this one because it's an example of really not a big change. This study looked at both how the patient felt about the exam and how the provider felt doing the exam. Because some of the resistance to change here, and I think it's because a lot of us are not terribly comfortable doing the exam, we don't really want to change it because we're already not that comfortable with the exam. So this changed the position of patients just a little bit by having them put their feet on the pulled out bed on a kind of typical exam table rather than in what is unfortunately often referred to as stirrups and should be called footrests. We'll come back to that.
Yeah, we'll come back to it.
And I'm just going to show you a picture. And it's basically this position. And some patients found it more comfortable, and most providers did not find it more difficult. So not an earth-shattering paper, but definitely shows that there may be small changes we can make that will make the patient more comfortable and won't hinder your exam. And we'll talk a little bit later about how setting this kind of thing up in advance can really make a difference. Another really important factor is understanding that the pelvic exam is going to be especially difficult for anyone who's experienced sexual trauma. So these are the numbers. This is from 2015 and they haven't changed very much. It is underreported. So it's reasonable to go into the room assuming there's a good chance that your patient may have experienced some sort of sexual trauma and that this exam may be fraught for them. So this is borne out in literature, right? When we have asked, patients have confirmed, yes, they've experienced sexual trauma. Yes, the pelvic exam is more uncomfortable. And yes, using elements of trauma-informed care can make the pelvic exam less uncomfortable. So in the 20 minutes that we have, we don't really have a lot of time to go over all of trauma-informed care. That's a whole nother topic. But these are some nice words to remember, the 4 R's of realizing trauma. So realizing that it may exist, right, that the patient may have had it. Recognizing the signs. So if you start to examine someone and they're feeling very uncomfortable, or as you're getting ready, you're seeing signs of anxiety, understanding that this may be related to trauma. Responding to those signs, so don't just keep going, stop. Say, hey, I'm noticing you seem really anxious. Do you want to tell me anything? Is there anything I should know? What can we do to make this more comfortable for you? and resisting the re-traumatization by recognizing those signs and doing things differently. And I would say preparing in advance, right? So if you start with this, if you don't wait until you're recognizing that someone is anxious and you ask in the beginning, is this a difficult exam? Or just say, have you had a pelvic exam before? Is there anything I should know about? That's often a really helpful start. And part of the issue is the way that we've learned to do pelvic exams. So people my age, I don't see any of you in this audience, maybe one or two, maybe, but we came from training that was really, really problematic. This is Ashley White's, and she kind of broke open this fact that 10 years ago or so, it was really not uncommon for women to have pelvic exams prior to surgery while they were under anesthesia. They did not consent for these exams. I remember as a medical student being asked to do an exam like this. In that case, it was a GYN surgery, so I think I didn't recognize that this was wrong. But they felt that, right? The theory was, oh, this is uncomfortable for students, it's uncomfortable for women, so we should just do it when patients are unconscious, and then nobody's hurt, right? So obviously that's insane. We realize now that, people need to consent to examinations like this. And in most states, it is now illegal to do an exam on a pelvic exam on a patient under anesthesia without written consent in advance, unless there's an emergent situation, right? But certainly not for the sake of education. Which leads us to the fact that there's been a lot of variation in the training. So that was kind of what was done before. That was clearly not adequate. You certainly didn't learn how to do a good pelvic exam on an unconscious patient. But now we really do rely heavily on the 1 or 2 simulated patient experiences that some people get in medical school, not all of them, most of them maybe, and then a very varying level of experience through rotations, right? Some people are going to get more hands-on experience than others. Okay, so given that that's how your residents are coming to you, what can you do? And they want to do well. Let us all understand that everybody comes to this wanting to do their best. So what can we do? What can we teach them on how to do better?
And that's a loaded question. So we wrote out a list of maybe like 200 do's and don'ts. And we're going to focus obviously on a subset of that. And we'll start with the don'ts and end with the do's. So for don'ts, a lot of it is the words that you use, a lot of it is nonverbals, and a lot of it is the processes that you use. So remember that it's not just having those back pocket phrases, but those are helpful, as we'll talk about in a second. But remember that complete silence is probably not a good idea unless the patient wants it. In-depth discussion of exactly what you're seeing when you're seeing it and how concerned you are is probably not the best idea if you're in the middle of a speculum exam. Again, unless the patient really, really wanted it and told you beforehand. Laughing, there's a time and place for everything. Maybe it's one of those pelvic exams that patient's super relaxed and like it makes a joke. Sure, okay, make a little giggle, but you shouldn't be like laughing like crazy. Saying words like, wow, oops, uh-oh. We talked about all of these do's and don'ts beforehand, and we have heard all of these from our trainees and even from colleagues. Saying things like, okay, this is going to hurt. That's also kind of a no-no. You want to warn your patients a little bit, but if you're telling them that it's really going to hurt and you're using the words pain, hurt, that's just gonna prime their experience and make it hurt even worse. So you can use words like pressure and cold gel, that kind of thing. Try to err on the side of those words as opposed to pain. Who in the world ever relaxed when you told them to relax? So don't say just relax. We had some other recommendations for what to say when you want them to relax, and Dr. Melville will talk about that in just a moment.
Just remember, this is very triggering for people who've had sexual assault experiences. This is what assailants say when they're assaulting someone. So really never say that.
The other thing is try to avoid any surprises. And some of the things like packed into here are things you may not think about. Every new sound, every new touch, especially, or every new sensation that they might have in their sixth senses, you should give them a little warning about, right? So usually we talk about progressive touch, and Dr. Melville will talk about that a little bit in just a second, but I like to have, like, don't go straight for it, right? So touch them on their leg, touch them on their thigh, and let them know that you're about to do it before you do. Tell them when you're going to make a little clicking noise on the speculum so that they don't think that something inside of them is clicking, you know? So no surprises. Another important thing is medical terminology. So when we're talking with the patient or when we're talking about things that we're doing when the patient's in the room and can hear, you have to make sure that you're choosing your words carefully. Now, if you go do a Google search on the word stirrups, you will find 100 images of horses and saddles, and you'll find maybe one image of footrests for a gynecologic exam. So these are footrests when we're talking about them in terms of the pelvic exam. You don't want to associate your pelvic exam with anything other than a pelvic exam and medical related things. So I always say footrests. The safest word for this one that I have found is gel. You know, that they ended up calling this product jelly, and it even looks kind of like jelly, like the food. So grape or strawberry, right? The other thing that I've heard this called is lube or lubricant. That has a sexual connotation. Even like these little tiny things that seem like they're, you know, not important, they can end up being important.
Okay, so what can we do? What can we do to do a better job? Again, that's a 20-minute talk in and of itself, and we're already a little over, so I'm going to go through it pretty quickly. But really, it's about setting the stage and talking to your patient first, making sure you're all prepared, making sure your room is going to stay private. If you're working with a learner, go over it first before, even if you think they know what they're doing, just at least once have your learner, tell you how they do a pelvic. Talk me through a pelvic exam. Tell me the things you do and say. What do you do if? You know, how do you respond to? So things like that. Um, Asking about prior experiences and really trying to give some ownership and flexibility to the patient. So if the patient says, yeah, I'm really uncomfortable, and you ask, what can I do to make you more comfortable? And they say, I really hate the speculum part of the exam. I just hate it. And you can say either, I think it's going to be really important for this because I really need to see this. What do you think? You know, how can we make it more comfortable? Or like maybe would it be more helpful for you to insert the speculum? Or maybe you can say, you know, I think we can not do a speculum exam this time, but can you swab yourself for the infections that we might be concerned about? That kind of thing. And also, some things that we can do technically, procedurally, is like making sure, again, that the patient's in a pretty comfortable position, making sure your learner knows to sort of orient the speculum at 45 degrees as they're placing it inside and then rotating once they're inside, making sure they understand like that sort of downward pressure can be really helpful for visualizing the cervix, making sure that they know not to take the speculum out while it's still open. You know, sometimes we think everybody knows that, but they don't. Making sure they know not to leave the speculum though open a little bit just before they're coming off the cervix.
Rather than like clamping down on it as they're in there or coming out, yeah.
And we're really, really almost at the end of time, but making sure they know, making sure you know what is normal, right? I think especially as we're having fewer pelvic exams, people don't know what's normal or a normal variant. And these are examples of normal cervixes or cervixes with different shapes or that have benign variants. So a Nabothean cyst or a pelvic or a cervical polyp. And cervical polyps can be terrifying looking, especially if you have a pregnant patient. So recognizing that and not saying, as I did once, oh my God, not oh my God, but saying, I think you may be having a miscarriage, and finding out later it's just a polyp. So making sure they know. And then knowing things like, what is the bimanual exam useful and how do you do it? I see residents all the time poking down, and they don't really understand that the idea is to push up, to see if you elicit pain from pushing up, or if you feel any kind of mass that's going to be very abnormal, right? Making sure they understand what that's for.
After your exam is done, the big take home here is just remember your job is actually not done. Now remember to bring the blanket down, cover up the used equipment because that can be a little distressing to see if there's a ton of blood or discharge on it. Offer to help her up, that's a big one. Fold the footrests up so she doesn't bruise herself, pull out the steps so she can get down. Give her a wipe, tell her you'll be back in 5 minutes to have the actual discussion about what you guys found, and then actually return in 5 minutes, because if you take an hour, she may be fretting that entire time. Now, we'll wrap up with take-home points. Number 1, anticipate trauma history, ask and clarify about their exam preferences, and also about their prior history. Avoid interruptions in the room, protect their dignity wherever you can. Be flexible and let them have a little bit of ownership with the plan.
The words you use matter, don't surprise them. Use progressive touch, so say what you're gonna do before you do it, touch progressively before you're touching the vagina. Making sure you and your residents know what you're actually looking for, know normal from abnormal, and make sure you wrap up the exam. And just to a little bit of information you can sometimes give to patients to empower themselves. I've recommended this book, and it's now a website as well. Whenever a patient seems like they could benefit from being a little more comfortable with their own body, Our Bodies Ourselves is an incredible resource. And I just think it's important to end on a positive note, especially in the current day and age. This is Michelle Broward. She redid the painting that we saw in the beginning, and that is Lucy, Anarcha, and Betsy in the positions of power, and Dr. Sims on the table. And she has opened a clinic at the site where the previous, some of his previous dastardly work was done. So things are hopefully, well, hard to say right now that things are looking up, but at least here they're looking up.
And at least this painting was bringing back around. Thank you so much for coming. Here are our references.